And good morning, bonjour. So it's my tremendous pleasure to be here in Montreal and with everybody here and make sure I figure out how this clicker works. And we'll be talking a bit about the Ontario Quality Standards efforts. There we go.
You just point it that way.
There we go. Okay, so I'm going to be, brief today. So this is a lot to cover. I'm going to just be skimming the surface. We'll be talking about some of the medical challenges, health inequities, and barriers to care for people living with sickle cell. Maybe I'll just ask, is there a way for the slides to be on the prompter here? Or
Yeah.
Okay, perfect. Reviewing recent initiatives, so homegrown in Canada initiatives to improve the quality of care in all the settings that someone with sickle cell would be receiving care. Examining what the elements are of comprehensive care when we talk about that in the clinic setting and what that looks like right now in Canada. And then discussing some of the inequities in access to treatment, which is going to be a topic everybody's going to be hearing a lot about as we proceed. So this is just going to be a start. So we all know about what happens in sickle cell, the sickling that causes anemia, the sickling that causes pain, the sickling that causes organ damage, and the suffering that that can cause. I'm going to talk again about some of these homegrown initiatives that have been brought together by healthcare experts in collaboration with community partners, with people, warriors living with sickle cell. And I'm going to start with something called the Consensus Statement on Care of Sickle Cell Disease. These were launched in late 2014. It was an initiative that was a collaboration between CanHEM, which is the Canadian Hemoglobinopathy Association. Really, it's a partner organization to SCDAC. It's focused in on healthcare workers who are providing care for patients with sickle cell across the country. So this was a collaboration between CanHEM and SCDAC. It was a document that's over 100 pages long and covers everything. Everything from the therapies through to the acute complications, so the things that can land someone in emergency department or hospital in the short term, and those long-term complications, as well as some of those elements of preventative care. This is available online on canhem.org if anybody wants to see it, and I'm going to be talking in a minute about a bit more updates. Now what we found is we did this huge initiative. It was over 50 people from across the country, specialists, social workers, nurses, physicians, with input from the patient organizations, and we thought this was important to roll out to say this is the standard of care, this is what the expectations are across the country. As we've heard earlier, as Senator Cordy mentioned, it shouldn't just be people who are living in the major centers, who are living in big cities. They should get access to this care. But as we went on, we realized, how do we spread this information across all the healthcare workers? Some people think of sickle cell as such a specialized area. And so, when we talk to emergency doctors or doctors in hospitals, they say, well, we don't know about these sickle cell consensus statement. This isn't something that's on our radar. And the patients would continue to tell us that they were suffering and that they were receiving substandard care some of the time. I'm showing here some illustrations that some of you may be familiar with by a very talented and unfortunately departed artist named Hertz Nazaire, who himself lived with sickle cell and in such a poignant way depicted what the suffering can be like. So others of you who might have heard me give talks before, I always try to think about this in a visual way, because when I speak with my patients, when I talk with their families, it always seems to me that they're experiencing two sets of challenges. They have the health challenges associated with sickle cell, which can be numerous, which can be very challenging, very cumbersome. But then on top of that, and really you think, why does it have to be this way? They have this heavy burden of the medical challenges, and then on top of that are health inequities and system barriers. And so in all of these initiatives that myself and many in this room and many who are not in this room have been working on, we're looking at how do we decrease the health challenges, and that's looking at access to treatment and researching new treatments, making sure that there are very good comprehensive care clinics, and then decreasing the health inequities and system barriers. This is another really, hits the nail on the head, this illustration. This is from Paula Tanabe, who's at Duke University in the United States, looking at the cycle that someone can get stuck in terms of barriers to care with sickle cell. You know, for example, frequent visits to the emergency department, clinicians who may not know, as we've been talking about the, you know, what the best practices are for care, stigma that can come with sickle cell, chronic pain and perception of addiction, and especially in our opioid crisis right now, it becomes very challenging sometimes when someone's coming in and telling an emergency department nurse or doctor, I need morphine or I need hydromorphone and this is the dose I need. It can unnecessarily set off red flags for these healthcare workers, and how do we break that cycle? And then of course racism and racism in healthcare, which has gone neglected for far too long and is only recently starting to come more to center stage so that we can tackle this head on. So I'm going to spend a couple of minutes here talking about some of the initiatives that have been happening in Ontario specifically. I'm based in Ontario. Alvin had referenced both the clinical handbook and the quality standards, and I'm going to walk you through a little bit of the history and a little bit of the content of those two initiatives. Talk about the work that's ongoing and so much more work that needs to happen in Ontario. And we're very happy to share, you know, these materials are available openly online for anyone in any province or around the world. And many of us are still very actively involved in this work and happy to support work in other provinces. So through a lot of advocacy by the Ontario patient organizations, by healthcare workers to the Ministry of Health, the culmination of about a year and a half of work in December 2017, this clinical handbook launched. I'm going to say I'm presenting this as a success story, but I'm going to be totally honest with you. It was a little bit, I guess as with anything where you're working with complex organizations, complex things like a Ministry of Health, it started out as one thing, and then what we got in terms of resources for the implementation was a very diluted version. It was initially set out to be something called a quality-based procedure, where the recommendations that came from this process were going to be there were going to be some key deliverables, some things that hospitals had to do, or else they wouldn't get fully paid. And if they did certain things, they would get paid extra. And so we thought, this is good. You know, sometimes you hear about a carrot and a stick. You know, what is the incentive and what would be the disincentive to giving bad care? In the end, the clinical handbook ended up being a huge initiative of over 25 people from across the province of Ontario, doctors, nurses, pain specialists, emergency department physicians, pediatric, adult, patient representatives, representatives from hospital administration from across the province. And the document ended up covering a wide swath of what the care standards need to be, with the focus on how treatment in the emergency department needs to look when somebody comes in with a sickle vaso-occlusive crisis. Not only did we have patient representatives in the process, but also the patient voice was woven throughout the document. There was a focus group that was done, and very poignant quotations, very applicable quotations from that focus group were sprinkled all throughout this long document to make sure that that patient experience was expressed. I'm not going to go into the actual details of it, just with the time that we have. This is really the heart of the document. It's a flow diagram that shows exactly what needs to be happening in what amount of time, talking about pain medication needs to be administered within 30 minutes of triage or within 60 minutes of arrival at the emergency department, making sure that people are triaged at a high level so that they don't sit and wait in the waiting room for a long time. Those were some of the key things. And then, of course, when we looked at the summary of the implementation recommendations, so when I talk about implementation, it's like, okay, great, all this information's here. How do we make sure that it gets used, that people really take this and run with it? There were a whole list of implementation recommendations and a big focus on education so that we could tackle these barriers to care. So the next phase of this was something called the Sickle Cell Disease Quality Standards. And these were launched just in January of this year. It was about a year-long process, collaboration between the Ontario Ministry of Health, which is now rebranded as Ontario Health, and the Quality Standards Department. There were, again, experts from across the province, some who were involved in the earlier clinical handbook initiative, many others who were coming into this with fresh eyes, with fresh legs and enthusiasm. We had representation from primary care, so from family medicine and community health clinics. And very importantly, one of our co-chairs was Serena Thompson, who was one of our lived experience advisors and who is well known to many in the SCDAC community as someone who's been very involved in SCAO, one of our Ontario organizations. So again, very brief, kind of quick summary of what this was. Or what came out of this, and the quality standard here, in a way, is similar to the clinical handbook. Has a lot of very important information, tools, resources, and guidance for what good quality care for sickle cell looks like. This quality standard went beyond what the initial clinical handbook from 2017 covered, in that it covered every setting that someone with sickle cell would be receiving care. So it speaks about what should it look like in the family doctor's office, what should it look like in the specialty clinic, what specialized access to things like pain specialists do we need to build into this network, this team that would be providing care, and what does care look like across the whole age spectrum, from babies all the way through to adults and older adulthood. Big focus on psychosocial, the mental health and just the life impact that living with sickle cell can have, and the supports that need to be in there. And a big emphasis, number one on the quality standards, racism and anti-Black racism, and tackling that. And in Ontario, there's been a lot of work happening to address that kind of across the system, and the health equity standpoint and the anti-racism standpoint has really helped to raise the profile of the sickle cell standards in terms of this implementation as well. So I'll encourage any of you who are interested you could just Google Sickle Cell Quality Standards Ontario. The website's here. I'm not sure if my slides will be distributed, but it's available there as well. There are a whole bunch of tools. It has all the details from the quality standards. There's a patient guide. There's what they call the placemat, which is just like a one page that has the details there. And then as well, there's for hospital data departments, it's got some guidance about how can they look at the data about whether they're achieving the goals and targets, so that they can really set targets to meet all of these standards. So when we look at education and system improvement, I think these initiatives have really targeted at the level of healthcare providers and hospitals, and working with provincial, and we heard a lot of work about the amazing we heard a lot about the amazing work that's been happening at the national level as well. We're really working through all of this to try to lighten the load of these health challenges and flatten out those health inequities and system barriers that really are unnecessary. In my last couple of minutes, I'm going to talk about what's being done to make sure that no matter what province or territory you live in Canada, if you have sickle cell or someone in your family has sickle cell, they have access to not only specialized sickle cell care, but to all of these elements of sickle cell care. So I'm going to come back to, again, these Canheim consensus statement, because in here there was a chapter exactly outlining this. What are the elements of a comprehensive care center, and what needs to happen to create a Canadian network? So, actually I'm going to jump ahead one slide. So if you go on the Canheim website, and I think this actually needs to be updated. We have our Canheim conference in a couple of weeks. If you go there, though, you can click on your province or region and find the information about, and contact information about pediatric and adult sickle cell clinics across the country. And as I say, at our upcoming meeting, the plan is to make sure that we've got this updated, because the exciting news is that this has been growing. And I know even recently, within the past year or year and a half, for example, in Atlantic Canada, they didn't have a formal adult clinic, and they now do through a lot of hard work and advocacy of the patient organization. So we do have clinics across the country. I can't even say in all the provinces, because for Atlantic Canada, they have that one adult clinic for all of Atlantic Canada. As far as I know, there isn't access to specialized care in a formal way in the territories. So there are inequities already in that sense. And then, I showed this slide here that looks like it's a lot, right? All of the spokes on the wheel of what needs to be brought together to have a full comprehensive care clinic. And then when you look at this second one, out in the little boxes, it's all really small, hard to see. But trust me, that's just the basics of outlining what each of those spokes is comprised of. And I've bolded some of the areas where, where might be challenges, where there may be inequities even between one clinic and another, or between one province and another. So, for example, transfusion support, red blood cell apheresis, so that's an automated red blood cell exchange. Not all centers have that, so that they could do a red blood cell exchange in an emergency basis. So if somebody, for example, was having a big stroke or multi-organ failure. Not everybody has the specialized MRI that we need to assess iron overload. Not everybody in Alberta, for example, I was liaising with one of my colleagues there, hydroxyurea is not covered for sickle cell disease for people on the provincial drug plan. The clinics have found a way to work around this so that most patients don't end up having to pay out of pocket. But even that's requiring advocacy and efforts on behalf of the patients. And then, of course, as we're going to hear more about today, the specialized treatments that are available, for example, in the United States and that are not yet Health Canada licensed, and things like gene therapy and hematopoietic stem cell transplant. Hematopoietic stem cell transplant is only available at a couple of centers across the country, and so looking at how do we make sure that if you live in a province that doesn't have that, you still have that on the menu of options if that's something that you would really benefit from. So this is our work. This is what we're here to do today, gathered together as patients, family members, advocates, healthcare workers, linked arm in arm, pushing to bring about the much needed change. I've got an exciting update, and so the Sickle Cell Consensus Statement that is now almost 10 years ago that we launched this, there's been a huge army of healthcare professionals working on updates to this. And it's going to be coming out in 2024. I heard from Ziad Sol, who's one of the co-leads, co-editors, and he let me know they've got 75% of the chapters all done, so they're just kind of working on the finishing touches. There's going to be more information about novel drug therapies, advances in transplant and gene therapy, more emphasis on the neurocognitive and psychosocial, and updates to all of the quality standards, all those chapters that I outlined. It's written in language that's targeted to healthcare professionals, but it's there as a resource for patients, families, and advocates. It's there as an advocacy tool. You can print off a chapter and bring it to your doctor. You can say, this is the standard that I should be getting, right? And including that comprehensive care and the elements of comprehensive care. So, all these levels of education that bring us towards system improvement, and the work we're doing here with SCDAC and AAFQ, working together with patients and families, because we know that educated, empowered patients and families take an active role in care and advocacy, and we're all working together to bring about this change on an individual and system level. So again, this can be very demoralizing to look at, this sense of an uphill battle with a weight that is too hard to bear. But we know that everything feels like an uphill battle, and we just have to think of the view from the top, and we just need to be working together to flatten that incline and to lighten the load on people who are living with sickle cell, and we need to work together to increase access to excellent care. Thank you so much.
Thank you so much, Dr. Verhovsek. We've left a few minutes in this time slot for questions. There are 2 mics on either side of the room, one right there behind Jenny or in front of Dr. Brian, and there's one right there on this side. So please feel free to get up, get to a mic, and ask Dr. Verhovsek any questions.
Thank you. Thank you for giving the whirlwind tour of everything that is happening. But I wanted to ask you, the comprehensive care, we keep using the keyword, and we have a very good example of how comprehensive care is being delivered in the world of cystic fibrosis. And why not take from there? Why stop short and not advocate for, in that Ontario quality standards, to have those kind of centers of excellence at par, at least, if not better than the cystic fibrosis, how the care is delivered? Why? Why stop short?
Oh, that's a good question, and I would say we're not stopping short. If you look in the quality standards, it really outlines the elements of what the comprehensive care should be, and they're very similar in terms of the interdisciplinary, right? We need nursing, we need physiotherapy, we need social work, right? Where I think things fall down, if I'm totally candid with you and everybody in this room, is like I had mentioned for that clinical handbook, where it becomes, okay, we're gonna develop these standards, we're gonna put on paper what this should look like, but then where's the funding? And so anybody who's been in, I'm looking at Jennifer Bryan over here, I know others in the room who have been involved in this quality standard. Every meeting I'm in, as a co-chair of the quality standard with the Ontario Health staff, at some point in the meeting I say, okay, but when the implementation, where are the resources going to be? What's the accountability going to look like to the hospitals? What's the accountability going to look like to the Ministry of Health? They're working on it. Doesn't feel reassuring every time. I have my own thoughts and concerns about that, but we do highlight cystic fibrosis. We do highlight hemophilia. In Ontario, those are 2 genetic diseases that have, for many years, had very robust, well-resourced comprehensive care clinics. And so we keep on hammering at that. We say we need to have the same funding, the same resources. So, your voice as a respirologist is so important there. Somebody who can see those discrepancies. Recently, our hospital newsletter reached out to, because it's Sickle Cell Month, right? So happy Sickle Cell Month to everyone. And so our hospital newsletter had reached out to our clinic team. We just celebrated our 10-year anniversary of our clinic. And it's been an uphill battle like this for resources all along. And the clinic, asked us, the newsletter, they asked us, what more do you need? And we said, this needs to continue to be resourced. We can't just say, okay, you've got your staff, but the clinic continues to grow, right? And they asked me, why did you get involved in sickle cell? I said, when I was training, I worked in the hemophilia clinic, I worked in the oncology clinic, and then I saw what was happening for people with sickle cell. I said, this isn't right. So absolutely, we need to keep on hammering away at that, and sickle cell requires the same amount of dedicated resources, and in some special ways, extra over and above, because to address the historical inequities that have been there. So thank you.
Hello.
Good, how are you?
I'm good. How are you?
Good.
So I think it's great, like as you said, for the 2017, we've got the clinical handbook, we've got the statement, the consensus statement, we have the quality standards. I'm on the same page as you, like where does the actual accountability? So it's great now that the consensus statement is getting updated, but where does it actually, how does it land on the providers? As a frontline provider, clinical nurse specialist, I want to appreciate how do we have all these resources. It's not that we're lacking resources, we have it. And people are aware of it. So how do we, like Jane Corday, it is fantastic that she's standing up there, that she is supporting sickle cell. I've known her for quite a while as well. But okay, so but how do we get it to the provider and to the patient? Because it's not impacting the patient the way it should. We have what we need, we know what we need to do. What is it as a group, like who do we need to more like, you know, congregate towards to help flip the script a bit to say implementation, like how do we make hospitals accountable? Because sickle cell, as you said, is one of the few that is not a QBP, because I looked at that too for the clinical handbook. Why is sickle cell not a QBP? But you'll have like, what's it called? What's that surgery? Oh, circumcisions, right? Or something along those lines. That's a QBP. So it's just interesting, like how do we make the change happen?
So at our table before the official proceedings started, I was just reflecting on my experience on the front lines in healthcare, feeling like I see very clearly the improvements that need to be made, the investment that needs to be made, meeting with hospital administrators, meeting with government officials, and a lot of times, to paraphrase my colleague, Dr. Forte, it's kind of a pat on the head and say, thank you very much for your commitment. Thank you very much for your passion. And then the meeting's over, and then you leave empty-handed. When I tell my patients that, they're surprised. They think, oh, you're a doctor working in the hospital. You should be able to make change from the inside. You're somebody who has leadership roles in the hospital. You should be able to have influence on how the resources are allocated. And for some strange reason, which we could kind of talk all day to try to understand, it doesn't always work that way. I'm not just saying this because this is a patient organization-led conference. I am saying this because it's the truth. The way to bring about change and the voices that need to be heard are the patients, are the families. It's the stories, it's the lived experience that you have. When you meet with policymakers, you are considered to be their constituents. For some reason, those people who are on the healthcare front lines, it can sometimes get filtered out. When patients, patient advocates, families, patient organizations come to policymakers, change happens. So I think we continue to work together, everybody bringing their strengths to the table, everybody kind of, again, arm in arm. But Karen, I wish I had, been working in this space for my whole career, and, in retrospect, looking back and seeing and very grateful for the incremental change that has been made. I think for transformative change to happen in a way where there's just robust, long-term commitment of resources that are going to continue to increase as the needs increase, it requires strong patient voice. Yeah.
Thank you.
Thank you.